Good afternoon, everyone. It's lovely to see all of you and a pleasure to welcome you to today's event, Advancing Women's Health with AI, Insights in Innovation. It's a collaboration between the Center for Health Law Policy and Ethics, the Bruyère Health Research Institute, and AMS Healthcare. My name is Vanessa Gruben. I am the Director of the Center for Health Law Policy and Ethics. Le Centre de droit politique et éthique de la santé est un centre interdisciplinaire pour la génération des nouvelles idées et preuves. The center, which consists of over 30 core faculty members drawn from a dozen disciplines, seeks to bridge gaps and foster the collaboration of different kinds of researchers and practitioners. I'd like to begin this afternoon by paying respect and gratitude to the Anishinaabe people, who are the traditional guardians of this land, by acknowledging their long-standing relationship with this territory, which is where I live, work, and raise my family. This afternoon's event explores the transformative potential of artificial intelligence in women's health and the innovative strategies that are emerging to improve healthcare outcomes for women across Canada. As many of you know, women's health is a critical area where AI has the potential to make a profound impact, whether through enhancing diagnosis, improving treatment options, or creating more personalized care pathways. We're excited to hear from our panelists today and to discuss how these innovations can help shape more equitable and effective healthcare for women, and to explore some of the current challenges to their use. In addition to today's panel, I'm also thrilled to be announcing with my colleague Kumanan Wilson the launch of a new and important research partnership between the Center for Health Law Policy and Ethics and the Bruyère Health Research Institute. This multi-year strategic collaboration will focus on advancing health, technology, and human learning through research that tackles the pressing challenges at the intersection of health law and technology. This new partnership builds on our past successes and expands our efforts to address some of the most complex challenges in healthcare, such as access to healthcare, health technology innovation, and the legal and ethical considerations that come with these advances. Through our combined expertise, we aim to tackle these issues from a multidisciplinary perspective, creating meaningful, real-world solutions. This partnership represents a shared commitment to improving healthcare, and we're excited to continue our work together to make an enduring impact on healthcare policy, practice, and outcomes. And I'd like to introduce Dr. Kumanan Wilson, who's going to say a few words.
Thanks, Vanessa. My name is Kumanan Wilson. I'm the CEO of the Bruyère Health Research Institute. Who here knows about Bruyère? Good, great. So for those of you who don't know about Bruyère, we're a complex continuing care set of hospitals. And our research institute conducts world-class research to maximize quality of life and shape the future of healthcare. Our research has 4 pillars. So Amy is one of our scientists who will be talking about the great work she's doing in AI and aging. We have memory aging in place in long-term care, palliative care, rehab and recovery, and social accountability. And social accountability encompasses global health and primary care. Anybody here do research in any of those 4 areas? Any palliative care researchers here? Aging? Great. Technology and rehab, recovery. Well, we welcome people to join our team if you are doing research in that area. Here are some examples of some of the work we're doing. You'll be hearing from Amy shortly. One of our scientists has developed a really cool virtual headset, the ones you use to play video games. And this is a virtual companion for people with dementia, so that as they age, using AI, the companion ages with them. Other scientists are using different ways to tackle existential distress at the end of life using magic mushrooms, of all things, and things like ECT, repetitive transcranial magnetic stimulation. I'm excited about this partnership for several reasons. As Vanessa knows, I have a strong interest in health law, and I'm just excited about the many opportunities to work with the Health Law Institute. And as Vanessa has said, the work we're doing is profoundly important right now. We have a crisis in our healthcare system that's affecting our older population particularly severely. We saw this during COVID. We saw the impact it had. And many of these issues not only involved healthcare, but they involved ethical, legal, and policy dimensions. And what we learned during COVID is we didn't tackle these very well. And bringing together experts in law, policy, and ethics with the great scientists we have at Bruyère, I think is the way we need to move forward. And at the heart of this, we believe technology is going to be critical to addressing these challenges. And that's where AMS fits in. Vanessa and I are both board members at AMS, and AMS focuses on technology and compassion. And that's what we both strive for at our institutes, to address the challenges of our aging populations, of all of our healthcare populations with compassion. Thanks.
I'd now like to call upon Jocelyn Bennett, who is the Director of Programming for AMS Healthcare, to say a few words. Jocelyn.
Thanks very much. It's my pleasure to welcome you here this afternoon to this important event where we explore not only the advancements in artificial intelligence, but also the profound ways in which these technologies intersect with compassionate, human-centered care. For those of you that don't know AMS, we are a small but mighty, self-funded charity that's committed to compassionate quality care for all Canadians in a system that's advanced by technology, innovation, and a rich understanding of our health history. We had hoped today to have some discussion about bridging our understanding of the past and present, but unfortunately, Dr. Jenna Healy, who's one of our speakers today, and also she's our Hannah Chair, which is an AMS-funded chair in health history at Queen's Law, was actually Queen's Faculty of Medicine, was unable to join us today due to a loss in her family. As we delve into the evolving area of AI and technology, it's essential to remember that this isn't just about data and algorithms. At AMS Healthcare, we believe that innovation must include an understanding of the human experience, prioritizing empathy and compassion alongside that technological progress. AI has the potential to transform healthcare, making it more personalized, more accessible, and as we heard from Vanessa, particularly in impacting in women's health. And if I can editorialize for a moment, I think with what's going on in the world these days, that's a critical area for us to really look at leaning into and seeing how we can use those technologies to improve women's health. But for us to be able to embrace these tools, we must ensure that they serve our core mission, care for each person in a way that respects their unique needs and humanity. To encourage this, our commitment as an organization, and we're very blessed to have very strong board members who help guide us in this work, is to support the development of scholars, researchers, and leaders in the healthcare system of the present and the future. This week, we launched our call for funding for our Compassionate AI stream, and we've put over $1.5 million in funding out, which is targeted at leadership fellowships in Compassionate AI and also some grant funding. So if you're interested, please check out our website. Talk to me. My colleague Ann Avery is here. We're always happy to chat with people about what's important, and we can have that conversation at the reception. So thank you so much for joining us on our journey as we create a healthcare system that not only embraces the power of AI, but also holds compassion and respect for all individuals at its core. Thank you.
All right, so I'm going to ask our panelists to come on up, and I will introduce you all. If you just want to come up and sit in front, that would be great. Is there enough space? Super. So our first speaker today will be Dr. Amy Hsu. She's an investigator at the Bruyère Health Research Institute and holds a U Ottawa Brain and Mind Bruyère Health Chair in Primary Healthcare Dementia. She's also a lecturer in the Department of Family Medicine. Her research uses population-level health administrative data to examine older adults' health and healthcare needs, especially in those living with dementia and individuals needing long-term care. Dr. Hsu is one of the principal scientists leading the development, implementation, and evaluation of RESPECT, which stands for Risk Evaluation for Support, Predictions for Elder Life in Their Communities tool. And that's a predictive tool supporting earlier identification of palliative care needs in older adults in home care and in long-term care. Following Dr. Hsu, we'll hear from Dr. Monica Parry, who is a professor in the Lawrence Bloomberg Faculty of Nursing at the University of Toronto and a nurse practitioner at Kingston Health Sciences Centre. Her clinical expertise has laid the foundation for a program of research to reduce the global burden of cardiovascular disease in women by 2030. Monica is an AMS Fellow in Artificial Intelligence and Compassionate Care and plans to integrate AI and attributes of compassion into At Heart. She's leading a research team to address the health and well-being of unpaid caregivers in Canada. And our third speaker is Dr. Sharon McGee. She is a medical oncologist at the Ottawa Hospital Cancer Centre, specializes in breast and skin cancer. She's also an assistant professor at the University of Ottawa, and her research interests include symptom control, pragmatic clinical trials, and the application of AI to improving patient care. So I'm going to turn things over to Dr. Hsu.
Thank you so much for that introduction. Good afternoon, everyone. It's my pleasure to be here. So first of all, I want to thank Jocelyn and AMS and Anne for actually the research I'm presenting today. I was just mentioning to Monica, I think was one of the projects that were funded in the first or second round of the small grants program. And so we're so grateful for that, just that Start at Sea funding, which I hope that this really is an illustration of how far that investment had gone. And thank you so much for inviting me to the panel today. So I won't actually belabor the point in terms of the gender inequities and also the sex-based inequities in terms of cardiovascular health, because Monica will speak to that. But I wanted to include this slide because we all know these gender inequities exist within our healthcare system. So women often are much less likely to access the same health services for the same diseases that men experience. And this is actually a study that was done where the investigator conducted a systematic review of 150 clinical trials that were used to develop the American Heart Association's clinical guidelines. And basically, the point was that all these trials were developed using a biased sample, so an inequitable sample where you're drawing recommendation for women's health using data that are generally based on men's experience. Now, my research specifically is actually in the area of dementia, and I'll get into that a little bit more. And where my research sort of intersects is using data to kind of help with early identification of healthcare needs. So specifically, the RESPECT calculator, which I'll speak to, as you heard in the introduction, is really tailored around personalizing care for people at the end of life. So since we're a relatively small group, I kind of want to throw a little bit of a interactive component to the presentation. So on the slide here, this is the distribution of individuals in Ontario who died over a period of 3 years. And these are the diseases that they died from. So terminal illness includes conditions like cancer. That's the largest group. Organ failure may be chronic kidney disease, people dying from renal failure. Frailty includes individuals living with dementia, COPD, chronic illness, and just multimorbidity. So you'll see that roughly the distribution is roughly a third, right, in each of these disease categories. What proportion of individuals dying from terminal illness do you think receive palliative care in the last year of life? Any brave souls?
Terminal illness?
That's right. Proportion, what percentage?
Of the terminal illness?
That's right.
Probably a very high
50 plus? Okay. Any other guesses? 80%. 80%. Okay.
I'm taking
20? Okay. What about organ failure? Which is low 20? Okay. What about frailty? Individual with dementia. Yeah. So we are actually doing a little better than I think most people give the Ontario healthcare system credit for, but I think we're pretty on the mark in terms of terminal illness. So nearly 90% of individuals with terminal illness will receive a palliative care consult in the last year of life. And that could be in the community, in the hospital, in long-term care settings. So that's across our entire healthcare system. Whereas organ failure, about 44%. So under 50% will receive that consult. Whereas for frailty, it's about 30%. And many of them are receiving care in our long-term care homes, in nursing homes. And so really, this is a problem that we had set out to tackle. And we know that when you look at the prevalence and incidence of dementia in our population, so the purple line represents the prevalence as well as incidence rates. So these are age standardized rates among Canadian women or females. And then the green line represent the rates among Canadian males. So you'll see that consistently the rates of dementia is higher among Canadian, female Canadian than male Canadian. And when you look at the burden of disease, because with the longer life expectancy of most women, you also see a higher number of individuals living with dementia also needing care. And what happens when individuals live with dementia approaches the end of life? So we know that when a person is approaching the end of life and they need referrals for palliative care, there is also a difference in terms of a gender bias in terms of who is referring patients for that service. So we know that female patients are much more likely to be referred by female patients, physicians, and the male patients are more likely to be referred by male physicians. So there is a concordance there. But what's interesting is the inequitable distribution in terms of who is a palliative care specialist. So you'll see that among the palliative care specialists and generalists practicing in Ontario. So generalists meaning that these are physicians who occasionally provide palliative care, where likely less than 10% of their practice is within palliative care. Most of them are family physicians. Some are medical specialists, so they could be an internist, as an example. Where you look at palliative care specialists, so these are individuals where the bulk of their practice is within palliative care. But you can see that there is an unequal distribution in terms of the number of physicians who are male and practicing in palliative care versus female. So there are implications in terms of who is getting seen and who is being referred. And so one of the things that we want to do is to start to remove some of that bias in terms of that referral. And so we took a look at the data that's available within Ontario. Most of the research I do is out of the Institute for Clinical Evaluative Sciences, or ICES. It's our provincial data warehouse. So basically, anyone with an OHIP card, with a health card, anytime they have an interaction with our healthcare system, that data is captured. So we have access to basically close to 14 million data points for each of the 14 million residents in Ontario. And so we took that data and then we basically looked at what happens after that care encounter. And can we use some of that information that's captured at that care encounter to predict the outcomes for the individual? So the RESPECT calculator, which stands for Risk Evaluation for Support, Prediction for Elder Life in the Community tool, it's a very long name, so we often go by the acronym. Most people know it as the RESPECT calculator. Was developed using over 1 million assessments of home care clients in Ontario. So we took over 1 million assessments that were conducted over an 8-year period in the home care program, and then we followed individually, prospectively forward for up to 10 years. So over that time, we know what proportion of the individuals who had received that home care encounter had died and what their life expectancy would be. And then we turn that data into a personalized risk calculator. So our community tool, our calculator for the community population is actually implemented on the website. called projectbiglife.ca. That's our team's knowledge translation website. There's a URL there, but also if you wanted to take a picture of the QR code, that also links you directly to the website. And basically, it contains about 30 questions that pertains to your health. So things like diseases, symptoms that you're experiencing, functional decline, cognition, your recent use of hospital-based services to predict your likelihood of dying in the next 6 to 12 months. And what individuals get out of that calculation is a personalized report that includes metrics that tells them about their life expectancy. So of people who are like you in Ontario, what is the average life expectancy for someone like you? And then we also provide sort of a confidence interval or a range in terms of survival of what we look like for, what we see in the data for someone who looks like this person. So often this is used in a clinical setting when the clinician might say, you know, the best case scenario, if you're doing well, if you're stable, your life expectancy could be as long as, let's say, 12 months, 15 months, 20 months. But if you continue to deteriorate, it could be as short as 3 weeks, 3 months, or 6 months. And so we use that data, and we have provided training to home care provider, primary care provider, as well as long-term care providers in using this report and the personalized metrics to inform discussions about what happens as a person's health continues to decline. So what sort of services might the person need? So as an example, you'll see they might need some support at home for someone who's based in the community. And then as they continue to decline, additional services may be introduced. So the calculator was really designed to help personalize care. So one, try to identify individuals who need services earlier. So then we remove the possibility that sometimes clinicians might have a bias when they come into these encounters in terms of who needs palliative or who should qualify for care and who potentially do not, because it is very difficult to prognosticate. And then secondly, we're trying to provide more data to help individuals have these conversations. So often, you know, if we're thinking about our personal lives, right? If you're thinking about what your plans are for the next week, next month, next year, it's helpful to know what that time frame is when you're talking about planning for trips, planning for really anything that you can think of in life. And so what we're trying to do is to kind of provide some time frame as parameters to help guide these discussions. So that you will know, you know, if your life expectancy is low, maybe you don't want to be on the long-term care wait list for 2 years. This is maybe someone that you might want to provide support for in the community and really augment the services that we provide to them in that setting. Versus if this is a person who's declining, whose life expectancy may be 5 or 6 years, maybe they could be on the long-term care wait list. And that's actually how it's currently being used in our home care program in the Ottawa region. So the problem, I think, with Respect and many other AI sort of based tool is that as soon as the algorithm is developed, it's out of date, right? And I think we talk about AI bias all the time, whether we're talking about language models, whether we talk about image generators, or in this case, a prediction algorithm. As soon as the algorithm is developed, it's potentially biased by the time, biased by the changes in the lack of changes. It doesn't reflect the changes in our demographic. And what it could happen is that it could lead to inaccurate predictions. It leads to biased outcomes, and especially when you're using in the context of guiding decision-making and conversations, it could actually create harm to the patient. And so one of the things that we're trying to do is actually to develop a framework that helps people to think about the evaluation and implementation of algorithms and AI tools within healthcare settings. So Doug Manuel is another physician I work with in our Project Big Like research team. And he sort of led this effort of conducting a systematic review to look at all the existing AI evaluation framework that exists so that we can develop a consolidated framework that really addresses the different components related to the implementation of prediction algorithm, especially in healthcare settings. So of course, there are the technical aspects to prediction modeling development and also evaluation and improvement. We're of course interested in clinical impact of these tools. And then there are other implications in terms of cost and resource use on the healthcare system, ethical, legal issues that are related to the use of these tools, and of course, issues related to data infrastructure and security. So this is the direction that we're moving towards. And one of the things that we're doing is actually we're leveraging a number of AI tools to kind of build this ecosystem around respect so we can continue to monitor its performance and update the algorithm. So some of the things that you may be familiar with are machine learning algorithm that kind of continues to test and tune the model to newer data that's coming in. So we're starting to leverage more and more machine learning-based methods and also AI tools to kind of build this ecosystem around respect so that we can continue to monitor its performance in the real world. So that's the end of my presentation. I think I'm relatively on time. Okay.
So welcome, and I actually want to do a shout out to AMS as well. Funded a couple years ago, and they've offered continued support, so thank you. So I'm going to have a little bit different look at things. I'm talking about AI and conversational chatbots for women's cardiovascular health, risk or reality. And the AMS funding helped sort of instill some funds into an ongoing project that remains ongoing, and I'm going to talk about that. So this is Nicole. She lives in Nova Scotia. She has 2 children. Her sister passed away at the age of 25. 6 months later, Nicole had her first heart attack at the age of 30. It was a non-STEMI and required a stent. She had a second heart attack when she was pregnant with her son, another non-STEMI, and she was only 34 years of age. Nicole says she's witnessed firsthand the inequities of heart health at all levels of care and prevention, and she is a strong advocate. And I've worked with Nicole from the outset of this project to develop something for women who live with heart disease. So deaths by cardiovascular disease. Cardiovascular disease is a leading cause of premature death in women. Every 16 minutes, a woman in Canada dies because of heart disease or stroke. And on this particular graph, you can see there's a bit of an upstroke around 2020, and that was an increase in deaths in women. And this was published in 2020, and most of these deaths are related to increase in risk factors, and we're seeing younger women die of heart disease now. These are, I have a particular interest in sex and gender, so there are sex-specific risk factors. There's well-established risk factors for heart disease, diabetes, hypertension, but they actually affect women differently than they do men. And then we have these under-recognized risk factors. So how do we pull all of these together to improve heart health for women? So importantly, symptoms are not recognized in 50% of women who have a heart attack. And actually, in 2022, there was a call to action from the American Heart Association to actually look at cardiovascular disease in women. Why are younger women dying? Why are we having this increase in deaths? So we have to look at the epidemiology. We have to increase awareness of women's cardiovascular disease. We have to increase access and delivery of equitable health care. So that took me on my journey to develop a web app. This is a progressive web app that a very interdisciplinary team developed with healthcare human factors at the University of Toronto. So this has been an ongoing project. You'll see that this was published in 2018, I believe, and this was phase 1. So we actually did a systematic review and meta-analysis. This is published in the Canadian Journal of Cardiology. And we wanted to learn if self-management programs could actually improve symptoms and outcomes for women who live with heart disease. We found a couple important points. One is, yes, self-management programs can, but programs have to be specific for women. We actually found in our meta-analysis that support from the healthcare provider can improve outcomes. So we took this knowledge and we met with women. We did focus group interviews, we met with healthcare providers, and we actually developed algorithms. And this is a very, very small clip of one of these quite extensive algorithms that we developed in this progressive web app. And you can see on the algorithm, there's green, we have yellow, and we have red indicators. And they actually put women into a category based on their symptoms. And I'll show you that in a minute. So this is what the web app looks like. So we actually took the algorithms, we worked hard on the language and the algorithms, and we created a chatbot, and our chatbot is named Holly. And chatbot Holly actually steps women through this At Heart web app. So when women first sign in, they create an event profile. Interesting, there were no body maps for women when we developed this. We actually had to create our own body maps for women, front and back. So women complete, you'll see that the chatbot is asking Holly questions about where her symptoms are, and it's very interactive. And then there are two other components. So we have At Heart's novel core feature set includes the event profile, but women also can do a heart check. So if they are having symptoms, they can sign into At Heart and have At Heart help them recognize their symptoms. And what the algorithms do is it actually compares current symptoms to their event profile. And if there's a match, it actually, you can see on this, this page, the chatbot actually compares the algorithms and tells the woman to call 911. Their symptoms are concerning. They're very much like the symptoms that they put in at the outset of signing in, that are symptoms of their last heart attack or their last visit to the emergency room. Tells women to call a family member, pushes the woman to the emergency room for a check. So we're not diagnosing, we're actually pushing women to get further assessment, because that is actually what's helping to increase the deaths in women, is they're not recognize their symptoms and they're not going to get assessed. So we also have a wellness check in At Heart. So this is based on the 7 categories from the brief pain inventory. Women actually complete sliders about their mood, their general activity, their social life, their relations with other people. And what chatbot Holly does is if they score low on any of these indicators, we have a library, and the chatbot actually goes into the library and will bring women readings, because we want to increase awareness. So the chatbot will go to the library and bring readings to the woman. And we have 2 components of the library. We have a component that's very extensive on women and heart disease. So women and heart failure, women's symptoms, women living with heart disease, and then we have a whole self-management component to the library. And you can just see some examples here. We have heart health and we have heart wellness. Each article is linked to an open access journal. And that's what women wanted. They wanted to read scientific papers. And what we then did is create a lay summary for each scientific paper. So that is helping with accessibility and language. But if women really wanted to read the science, they could read the science. So that's what we have for the papers. We also have part of our library has women sharing their stories. This will build on this in the future, but right now it's a her story section of the library. This I just want to show you. In the middle here are phases. Phase 1, which I talked about. Phase 2, I talked about. When we built the progressive web app, it's built so that women can access it on their home, on their computer, at their home, on their phone, on their iPad, and they can read articles anywhere. We've just finished our phase 3 pilot trial, and now we have put in for funding for our phase 4 trial. And I included this because I wanted to show you with the usability testing, there were only 2 important things that came out. 1, the font was small on some of the screens, and 2, they thought the chatbot was a real person. And so we actually had, and so we worked so hard on the language. So we actually had to create a tab in our web app to say that Holly is not real. She was developed by real people and experts in cardiovascular disease, but she is not a real person. So part of the funding that I had, we did a systematic review looking at patient-facing chatbots. So I have an interest in developing the chatbot and simulated applications in cardiovascular disease. This was a rapid review. We found 22 studies that were published between 2010 and 23. About half were women, which I was pleased to see that. But you can see that 88% are white, and we see that in a lot of the evidence. People either don't report race or ethnicity, and if it is reported, it's predominantly, participants are predominantly white. There was only one Canadian study, and it really looked at Alexa, so not really a healthcare chatbot. Chatbot roles included being trustworthy, reliable, showing empathy, supportive, and adaptable. Platforms included interactive voice response systems and SMS. And most of these are rule-based. None of them actually we found use large language models, and ours is rule-based. And I actually work with a cloud architect, and we've talked about changing rule-based to some AI algorithms, but right now it's a bit risky because, as Amy nicely pointed out, a lot of the evidence is based on men. So I think it's a safety concern. So what we're doing now is we're trying to train our chatbot to generate automatic lay summaries. So we did some prompt engineering and fed these into ChatGPT and tried to get ChatGPT to create a lay summary that was similar to the lay summary that we wrote. These are some examples. So one of these is written by us, and one is written by ChatGPT. And I'll give you a second to see if you want to guess if the one on the left is written by the chatbot, ChatGPT, or the one on the right. So we asked the chatbot to make it lay language, avoid jargon, make it professional language. So who thinks the summary on the left is written by ChatGPT? Who thinks the one on the right? So the one on the left is written by the ChatGPT. Yeah, so basically we've actually formulated that we can actually train the chatbot to automatically generate a lay summary, which is what we want. But I want to actually take that one step further, and instead of us building the library for women, it would be really nice if women could ask the chatbot, I'd like to read an article on heart failure. So can we actually do that? There was a paper published in Nature actually it was published in 2024. It was an editorial, and someone actually tried to train the chatbot to search the library system. And the chatbot actually searched and brought back papers. But when they looked through the papers, the chatbot provided information that was not related to the topic at hand. And there were several articles that the person couldn't find, even with the DOI going to PubMed. So this is really about hallucination. The chatbots can be quite believable, and that's a safety risk. So although there's room for movement, we just have to be cautious in our approach to, I think, how we're using chatbots. So I'm going to end there. Is this, risk or reality? Can we use large language models everywhere to sort of shift the paradigm? What about the ethics, which Amy mentioned? Information accuracy, what about regulatory frameworks and privacy and safety for people? So thank you.
Good evening, everyone. My name is Sharon McGee, and I'm a physician at the Ottawa Hospital Cancer Centre. Apologies for the gravelly voice, I'm just getting over a respiratory illness. So I'd like to talk to you this evening, and thank you all for coming, about our team's use of artificial intelligence to try and improve symptom management in cancer patients. So to begin with, our focus was on patients with breast cancer. As you may be aware, breast cancer is the most common cancer diagnosed in women. About 1 in 5 women will receive a diagnosis of breast cancer in their lifetime. It mostly happens in older women over the age of 50. However, women under the age of 50 can also be diagnosed. A common treatment-related suite of symptoms that we see are what are referred to as vasomotor symptoms. So this can include hot flashes, night sweats, chills, and palpitations. Vasomotor symptoms are actually seen in natural menopause as women age and kind of periods stop, and they can be quite common and are equally challenging in that period of life. But they are also commonly seen in relation to breast cancer treatments such as chemotherapy and anti-hormone or endocrine therapy. And really all patients will be receiving with breast cancer some type of this therapy. We know that older women who are already in menopause, when they are treated with these therapies, about 1/3 of them will experience these bothersome symptoms, and it's even more prevalent in younger women, where 90% or more of younger women treated for breast cancer will experience these treatment-related vasomotor symptoms. So it is a significant problem. We had conducted patient surveys of over 300 patients, and this supported the fact that these symptoms are common, they're distressing. They had told us also that they are under-addressed. They're not really asked about in the clinic. It's often perceived as, women's problems, and they're poorly managed. Even when they're brought up, they're not adequately addressed. We surveyed physicians treating breast cancer patients, and we found that they were aware that it was a problem, they were aware of various different treatments, but they found it challenging to know what treatments to recommend and how best to manage this, despite the fact that there are clinical guidelines there. So overall, vasomotor symptoms are a really serious problem in breast cancer patients. They impact quality of life. Most importantly, they impact compliance with cancer treatments. We do have some patients who have such disruptive, bothersome symptoms that they may decide to stop breast cancer treatments, curative breast cancer treatments. And so that can impact their chances of survival from breast cancer. So that's so important. And they also impact healthcare use, right? We have, unfortunately, patients need to come back and back because of these issues. And for curative patients, they impact their ability to return to normal life, return to the workforce. So it's a real problem. We also conducted a systematic review and meta-analysis of all the evidence-based strategies for the management of vasomotor symptoms. We confirmed that there are lots of different strategies, different types of categories, or lifestyle changes, complementary alternative medicines, prescription-based medicines. We identified, though, many limitations in the data. Often the data was derived and extrapolated from non-breast cancer patients. The trials that were conducted typically investigated and compared very limited number of treatments. The trials used different vasomotor symptom assessment tools, different types of analysis. There were different definitions of benefit. There was a significant lack of patient-centeredness in trials, lack of consulting patients about what they would want to do to manage the symptoms, what would be acceptable for them, what for an individual woman would be a definition of a benefit, rather than the trial deciding, well, if you have this improvement, we think that's good. And we saw that most of these studies used traditional statistical analysis techniques, and it really failed to capture the interactions between the many different variables. And really, that is one of the big challenges of trying to address these problems, is the fact that there are so many variables to how women experience vasomotor symptoms and how they are effectively managed. From the patient perspective, the experience of vasomotor symptoms can be influenced by demographic factors, so their age, also ethnicity can come into play, social factors like smoking history, other underlying health conditions. As we said, sort of the difference from woman to woman in their perception of the severity of their symptoms and in their definition of what they feel would be a benefit or an improvement in that. And they're also their preferences for treatment. Some women may want to take a medication to manage it, some women may not. They may already feel that they're on enough medications. The cancer too plays a role. There are different types of breast cancer, different treatments, different types of cancers have different risk and prognosis, and all of this can impact on the experience of these symptoms as well. And as I mentioned before, there are a lot of different treatments for vasomotor symptoms out there, lifestyle-based, complementary and alternative medicines, prescription medications, also strategies that look at trying to alter or change the cancer medications to address the symptoms. And each of these different strategies have different proven efficacy, and there are different associated side effects. And particularly with prescription medications, women may be taking on another suite of side effects in addition to their vasomotor symptoms that they may not find acceptable. So our team asked, could there be a role for artificial intelligence here to help address this problem? Given the fact that we know its ability to analyze large data sets, looking at multiple interacting variables, to be able to identify complex patterns and relationships, to learn from experience without explicit programming, and as our panel have shown, to be able to develop these models to predict, interactions and outcomes. So here's my certainly big thank to AMS Healthcare. Through their support, we were able to conduct a pilot prospective cohort study. We enrolled patients with breast cancer at the Ottawa Hospital with treatment-related vasomotor symptoms, 127 in total. We offered them the choice to choose their preference of intervention, be it lifestyle modifications, complementary alternative medications, prescription-based, or making an alteration to their cancer therapy, discussed with their directing oncologist. We used a validated vasomotor symptom assessment tool, which was conducted at baseline and 6 weeks into their chosen strategy. And this assessment tool was actually conducted and sent to patients through their electronic health records, through MyChart, which is something new that we hadn't done before. We did regression tree analysis to model the multi-level interactions and to predict intervention effectiveness in individual patients. Through that study, we were able to develop a new weighted change score that was actually able to predict a more meaningful benefit or improvement in vasomotor symptoms for patients. And we were able to develop a preliminary model to try and predict effectiveness of interventions for an individual patient based on what their preference would be for management. So the challenges of this type of work are many, and we were fortunate to be able to thrive in this respect in many ways. So you really need the right team. And so I'd like to say a big thank you to Dr. Khaled El-Aman. So he's the chair of medical AI at the University of Ottawa, and he runs the Electronic Health Information Laboratory, and he was really instrumental in guiding us in conducting this analysis. Dr. Mark Clemens at the Ottawa Hospital and ORHI is the lead of the REACT or Rethinking Clinical Trials program. And this is really a very innovative, pragmatic clinical trials program that really works to break down the barriers that patients have to participating in clinical studies, and in that way, really helping to break down inequities in research by making it easier for different minorities to participate in research. And certainly to Dr. Catherine Cole, who was the fellow who was spearheading a lot of, our excellent fellow spearheading a lot of this research with us. And as I said, funding through AMS Healthcare was really instrumental to this project. We sort of conceived this around 2020, 2021. We applied for multiple funding sources locally through the Ottawa Hospital, ORHI, larger national funding projects. And it was a challenge, and there was a lot of reluctance about our use of AI. I think at that time it wasn't as common, not understanding what the benefits would be, feeling that a traditional statistical approach would have been, maybe safer. So having a dedicated program that, funds this AI-based research in healthcare is really instrumental. And as always, thankful to our patients for contributing and participating in these studies. So this research is certainly in its infancy, so it's inspiring for me to be here today with the panel and to see your research and how you've kind of moved it on to developing these tools. And that's really where we'd like to take this study, is to conduct a larger prospective trial with incorporating all of these evidence-based vasomotor interventions, again, to have that patient-centered approach, allowing patients to decide what's the best intervention or interventions for them and what their goals are for improvement of their symptoms, to be able to apply our new novel weighted change score that we developed that really performed a lot better than the older scores used in previous trials. Older tools that were used in previous trials, and to apply our preliminary model and to develop it further to allow the creation of a tool that patients could use alongside their physicians to try and identify the best intervention strategies to manage their individual vasomotor symptoms, because it is such an individual experience. So yes, thank you all for coming this evening and for listening to all of our talks. Thank you to the organizers and the panel.
All right, so we have about a half hour. Thank you for those wonderful presentations, for some questions and discussion. Anyone want to get the ball rolling?
That's a good question. And you're right in that it's a little bit more personalized, so you can't make one big swift generalization that it shouldn't be used on any woman. We haven't thought about that. There's other sort of tools like the chatbot. From women, they want to see more personalization, so they want a face to the chatbot and a language that they can manage. So we're going to build that part of it. I can see that might be a way to go down the road with algorithms and use of AI for HRT. We developed it as a non-medical device, and we were very careful about that. And we had it assessed by Health Canada. So we were careful not to make diagnoses or recommendations on medications because of the legalities. And so we chose to push women for proper assessment based on their symptom matching from their acute coronary syndrome to their current symptom. So we stayed away from that medical device part. Now, the next phase 4 trials will hopefully see this integrated within one of the hospital systems in Toronto, where it can be integrated with the lab system. There's the way we built it, there's much more we could attach to it. So that might be something down the road, but that brings a whole other sort of kettle of fish, I think, in terms of risk.
Yeah, great question. So I suppose it's a little bit different in the general population and breast cancer population, but in general, you're right that there was sort of a swing against HRT, and then it kind of came back into favor, seeing that there can be benefits for certain patients, if it's correctly used. That menopause comes with an increased cardiovascular risk because estrogen has a protective effect for women. So it certainly can help to mitigate the cardiovascular risk associated with menopause, in addition to other things that we see in menopause, like decrease in bone health. The challenge in breast cancer is, really the most effective treatment for vasomotor symptoms, which is, I suppose, the tip of the iceberg of the experience of menopause. Is that in breast cancer, most patients with breast cancer will have estrogen-driven disease. Estrogen is at kind of the basis of it. So therefore, recommend against using hormone replacement therapy, because that may put them at increased risk of breast cancer recurrence. So that really removes one of the most effective treatments for vasomotor symptoms, and you're left using other strategies, which can be challenging. But to speak to that, some women are so bothered with breast cancer by their symptoms that they may decide to go back on HRT, even though they had a diagnosis of a hormone or an estrogen-driven breast cancer. And really, a lot of that is due to kind of poor management strategies. I'm sure that if we had better strategies looking at the other non-estrogen management strategies, we could support these women better and, hopefully try and avoid having to put them back on a medication that really could be harmful to them from a cancer perspective.
No, they weren't disappointed. And it wasn't only the patients, it was some of the physicians that helped us do the usability testing. We worked hard on the language to make, it was driven. We had a patient advisory group, so it was built by women for women. My initial at the outset was to build it on an already existing app, which was developed for adolescents with chronic pain. But women wanted a device or wanted accessibility to read articles. If they were in the dental office or the doctor's office, they didn't want to read the articles, go back home and read them on the computer. So that was a huge accessibility issue that we couldn't manage with what existed. So we took a step back and built it and built the chatbot is built on what we found in our systematic review is that support from healthcare providers actually can improve symptoms in women. And so that's why we went down the chatbot route, because that chatbot is sort of like that healthcare provider. We do say that the chatbot's not real. Full disclosure, that's now there built into a tab on in the web app to say that it's not real. They weren't disappointed. They actually feel like they get support from Holly. And interestingly, if women flag in the red zone, so they have a match of their symptoms, and Holly suggests they tell a family member, call 911, go to Emerge. There is a part in the algorithm if women are on nitroglycerin, Holly will tell them to take nitroglycerin as they were prescribed. And then Holly checks in with them in 5 minutes to see if they still have symptoms. And if they do, Holly tells the woman to take another nitroglycerin and call 911. And then the chatbot actually follows up with the woman to see if she went to the emergency room. And if she did, how she was feeling, and if she didn't, why she didn't go. So we have all that data from our pilot trial. So yeah, it's very supportive. She's very supportive. They are very supportive. And she doesn't have a face, or Holly doesn't have a face right now, but women want a face. Like there's certain things we learned in the usability testing, and we just didn't have the funding to put all those things in. So we built it as good as we could build it, did our pilot, and now we are asking for some more sort of nuances to build it a little better. Yeah, for sure we are. That's in our ask, and it can be connected to both an Apple Watch and a Fitbit. Yep, that's our next step, is to actually do that connectivity. Women want to see evidence. Yeah, good question. You know what, I think it has, but I've not done that, but that's something, like I think you can actually put the evidence together, but I've tried to do some reading on that, like to collate the good evidence and train the chatbot just to go to the good evidence, but I couldn't find that existed. So maybe my colleagues know a bit better about that. But
Yeah, I think it depends on the type of data that you're looking for. It doesn't always exist, and I think you risk, because anytime you amalgamate data sets, you're making some assumption about comparability between these data sets. And so unless they're comparable populations and similar measurements, I think, I don't know if this is one of the practices that would be recommended per se. But I do think that there are efforts to at least like routinely assess the data set so that you know where the biases might be and where the errors are. So that at least when you're building these tools, you're aware of their limitations.
Yeah, I know there's other apps that do that. Our app doesn't do that right now. It's really focused on the woman making the decision to get assessed. So we're just trying to push her. I mean, that's a gendered thing. Women delay because they have other things to do. So we're trying to show them that it's important to take care of yourself. And actually, we had to change our algorithm because we did not initially have in there, you should inform a family member. And most of the women we met with said, well, we can't leave without someone knowing where we are. And so that's why it says, tell a family member or a friend, and then go and get assessed.
I hear that. Yeah. Rachel.
I don't think it's the patients anyway. You know, we continually saw the patients are very open to it. I think they're seeing it in the media and other applications. I think from our perspective, it was sort of reluctance within sort of research groups or communities, or reluctance with physicians, you know, thinking, oh, can this really, you know, I don't know, we've got all these guidelines, we should really follow those because this is just a new approach to doing things, and you know, not believing it, you know. So I think as more of these tools are developed and we get more used to using them, because I suppose even as physicians, we don't use these type of tools enough within the clinic. So it's going to take us, you know, in whatever discipline we practice in, to become more used to it. I think actually the patients are a little bit more progressive and open to this research, and you know, because they're already using their phones for different things, and you know, getting that information. So yeah, I think it's kind of actually research groups and healthcare providers. I would say you know, in years gone by they were, but and I actually I'm fortunate to sit on the research board with the University of Ottawa and OHI. So we're seeing more and more of these studies coming through, and actually people are more receptive. Again, it's just being that knowledge, right? You know, becoming familiar with it, what's the concept, and we're all using AI in different capacities. You know, obviously we're using it at the hospital, helping us with documentation. So I think the more and more it comes into everyday life and more into clinical practice, I think that and into research will become more familiar, and it'll break down those barriers. But I found the patients more receptive than others.
I mean, I do find that there is still a technology barrier for a lot of people, right? I think not everyone knows how to interact with a chatbot.
For sure.
And, you know, for some of our prediction algorithm, we've had people come up to us like, well, my doctors told me I have 6 months left 4 times. I'm still around. So there's like this trust and like understanding about what the technology is doing, what's capable of doing, what its limitations are. And I think there's still some education that needs to happen there.
I can answer for ours from a patient point of view. Most of the patients in our pilot trial were white. So I think certainly pushing it out and increasing awareness amongst the non-white populations in Canada is important. You know, that's for accessibility, and I think digital health, you know, may have some accessibility issues anyway in some populations in some areas of Canada that we need to work on, but we're sort of cognizant of that and building it so that it incorporates those race and ethnicity. We have some self-management strategies that include drumming, for example, for Indigenous people.
Well, I think one thing I think is that hopefully a lot of these tools empower patients, right? And they can start, you know, using them themselves and getting that information, getting that education, and then that allows them to better define what's important to them and then approach their healthcare provider with it, right? And at least they go, you know, educated with their, you know, these are the strategies, I think I would like this, or that this is telling me this might work for me, or that, you know, the app is telling me this is my risk, I'd like to focus on these risk factors. So I think hopefully maybe through that, through patient education, patient empowerment, that these tools, you know, would be helpful to break down those existing barriers. Yeah.
Yeah, if I could just, I mean, it's such an interesting question. I think AI has the capacity to improve algorithm performance. So certainly you can tailor the estimates and the risk more to the individuals, right? So if there are these sex-based differences or gender-based differences, it could tailor the algorithm to the data if it's high quality data, it's reliable data that you can actually build the prediction model in. But I think that the issue is that the bias is not in the algorithm or the data itself. The bias exists in the society that we live in, right? So part of it is how we're choosing to use the algorithm, who's choosing to use these algorithm and tools, and that continues to kind of contribute and perpetuate some of that bias. So I think that's why I think it's so important to have that framework to think about how you're going to evaluate the performance. So at the minimum, you should look at whether or not the outcomes differ, right? So these are data points that you can collect, and you can look at how the algorithm's performing, how the user of these algorithms or these tools are performing on these outcomes. But I do think that the broader, like what AI solve this for, I don't think so. I think there needs to be a framework and people kind of guiding how these tools should be used.
Can I make one comment? just about empowerment, sort of building on your comment, Sharon. Because ours is for patients, and so women wanted to feel empowered. So they have the ability in the app to actually print out or bring up a screen that shows their symptoms when they had their last event and their current symptoms, so that when they go into the emergency department, they can validate the fact that they're there and they shouldn't be sent home. That was something important for women that informed us, because many times they were sent home from the emergency room. So it's kind of a different look, but it's trying to empower them to advocate for their own health.
I mean, I'll take the first question. It's something that our team thinks about a lot, because as a public-facing calculator, I could calculate risk for my neighbor if I know enough information about them. I do it for my parents, whether they want me to or not. As a researcher, I find it informative for me as a daughter, as a caregiver, as someone who cares for them. That information is important for me. A lot of time, I think when we introduce these tools and calculators, one thing that I think we want to think about is how a person approaches their own decision-making, right? So some people are, it's what we call a shared decision-making model. So they prefer to have that information shared with their loved one, their circle of care, and have that discussion. And some people only want to hold that information for themselves. And some people don't want that information at all. And part of that is actually getting the consent, right? So this is the part that we've been thinking about, trying to kind of build into all of our tools, which is to assess the level of consent. Like, how much do you want to know? How much do you want your people within your circle of care to know? And how much of it do you want it to be a shared decision-making process? There isn't an easy way to do that. So it is something that we think about a lot. But it is something that we're cognizant of, which is, it has to do with, privacy of health information, right? And being respectful, I think, to people where this is the information where it's about pertaining to them and what their preferences are for their care.
Yeah, no, I think great question. Sorry, just I suppose because you were asking maybe about the last presentation, but I suppose we think of when we do these tools, there's maybe a component of patient choice. They're going into using it, but it's a great point to think about that, maybe they could be used by others before and then presented to the patient. So that concept of, yes, having consent to use these types of tools and using, and giving the patient the information or person the information before they go, look, this is going to ask you X, Y, and Z and give you this, do you want to do this? So I think, yeah, it's a great point to remind us of, yeah.
Sure, I'll go first. So I guess language in terms of localization, that's a straightforward piece in terms of translating a sentence from one language to another. Now the meaning might be different, right? So I think the interpretation is that it's a challenging part. So in the work that I do, which is surrounding palliative care, there is such a strong role in terms of cultural understanding and acceptability of the concept of death and dying, like what that process should look like. And so when we develop our algorithm, which is looking at whether or not the person needs palliative care, and the person could have that need, but sometimes it may be difficult to share that information if they're part of a culture. So from the Chinese culture, I'm speaking from my own personal experience, this is something that it's taboo. You don't talk about death. Right? People avoid the number 4 because it sounds like death in Chinese. And so how do you actually share this information and making it culturally appropriate and adapted? I think that's where more research needs to happen. So I think the language is the first piece. I think there's some barriers there. I think that might be a little bit lower, especially, in the Canadian context, our data is actually quite diverse. And so you are able, at least with some of the population level data, you are able to actually capture a huge rate of diversity and evaluate against that. But in terms of how you use it and adapting the usage so that it tailors to different populations need, different cultural needs, I think is still, an area that needs more work.
Got time for one final question. Yes.
That's a hard question. No, it's a good question. And we put in a grant and it's currently under review, and it is an implementation trial. So it is focused on reach. But what we hope is that Holly will become the face of heart disease for women in Canada. And if, no, not yet. You're right. But she can have many faces of, different colors. And she could be, like, we have support from the Heart and Stroke Foundation. So Holly could be on the Heart and Stroke Foundation's website. And I do some other work with the Ontario Caregiver Network. And so, and in caregivers, because they bring an added risk for heart disease. So we're trying to increase that knowledge about risk in that population. So Holly can be on several websites, and that's part of the implementation project, is how can we get the face of Holly out there so women know about this. And at the outset of its development, it was never meant, it was to be free. It wasn't to, and we built it as a progressive web app without wireframe. So it's easy to update, easy to make changes. It's right now made for secondary prevention, so women who have diagnosed disease, but we want to put in an arm for primary prevention, and even for accessibility to the library. And that's why I think it would be great if we could train a chatbot to actually search the library with reputable papers and then automatically generate a lay summary. So that would help increase the accessibility. The language is a difficult one. That's kind of another step, because it's not just the language, it's the context in which that language is embedded. So good question.
I guess I could just speak through the reach of our web calculators. So the first week that the Respect calculator was launched on Project Big Life, I think we had about 400,000 visits on the website. And I ended up doing, and it's also because the heading that comes out in media would be the death calculator. And so I ended up doing a bunch of interviews there was a podcast in Ireland, there was in Hong Kong, and it was just about this group of scientists in Canada developed this death calculator. I did find, though, that they gave me the opportunity to educate people about palliative care, and that's the most important thing. And so I think in terms of reach, I think there's the partnership that's important, making sure you're reaching the right people, especially depending on who your target audience is. For us, a lot of it is kind of helping providers have these conversations with patients. But the reason why I put it on the web is also to empower patients to bring this forward to their providers. So we made sure that both mechanisms are available, both the free version, but also what we integrated into the EMR. But in some ways, I think I'm a little bit less discriminant when it comes to how it's reaching people. And if it gets out there, it helps us to kind of talk about palliative care. I think that's our goal. And periodically, we do kind of send a survey for people who use the calculator, so we know who they are, what they're using it for. Did it educate? Did it provide some level of education for them? What's it helpful? And so that's one way for us to kind of assess that.
All right. Well, I want to thank our panelists for some excellent presentations and really rich discussion. I also want to thank AMS for their generous support of this event. And of course, Bruyère for always coming out to and supporting the Center for Health Law Policy and Ethics. And to thank everyone who joined us tonight for such an excellent set of questions, a really rich discussion. So I'm now going to invite you. We have some snacks and some drinks in the reception area, and I hope to see many of you there, meet many of you there. Thank you.